Buenos días, tengan todos ustedes. Gracias por acompañarnos un miércoles más en la sesión académica de pediatría. En nombre de la Escuela de Medicina y Ciencias de la Salud del Tecnológico de Monterrey, les doy la más cordial bienvenida a la sesión académica de pediatría. El día de hoy cerramos con broche de oro el módulo de traumatología pediátrica con el tema Spinal Problems in Pediatric Patients. Y para presentar a nuestro ponente, le cedo la palabra al doctor Aurelio Martínez, al cual al mismo tiempo agradezco por haber sido nuestro coordinador de este mes y ayudarnos a organizar increíbles ponencias que nos servirán mucho para nuestra práctica. Muchas gracias, doctor, y adelante, por favor.
Sí, no, muchísimas gracias a ustedes por la oportunidad de participar. El día de hoy vamos a escuchar la presentación del doctor Stuart Weinstein. Él es actualmente, bueno, él es cirujano, es un ortopedista pediatra con un especial interés en patología de la columna y problemas de la cadera pediátrica. Tiene múltiples publicaciones, de hecho más de 200 artículos en revistas, incluyendo el New England Journal of Medicine, el Lancet, y varios estudios de seguimientos a largo plazo que son pues prácticamente piezas invaluables que no existen en la literatura universal, además de los estudios que él ha podido publicar. Ha sido presidente de la Academia Americana de Ortopedia, de la American Orthopedic Association, ha sido presidente también de la American Board of Orthopedic Surgery y también de la Scoliosis Research Society y de la Pediatric Orthopedic Society of North America. Él es desde hace más de 40 años profesor de cirugía y traumatología ortopedia pediátrica y además profesor de pediatría en la Universidad de Iowa. Y el día de hoy vamos a escuchar, como ya mencionaron, patología de la columna vertebral en el paciente pediátrico. Gracias y adelante.
Hey, good morning. I'm Stu Weinstein from the University of Iowa, and it's a pleasure to be with you today talking about spine problems in pediatric patients. This morning, we'll be talking about scoliosis, idiopathic, the most common type seen in adolescent group. We'll talk about early onset scoliosis. We'll talk about scoliosis and other conditions, briefly congenital, associated with neuromuscular disorders, syndromes. We'll talk a little bit about kyphosis. The most common kyphosis you see besides postural kyphosis is Scheuermann's kyphosis. And then we'll end by talking about a very common condition in teens, which is spondylolysis and spondylolisthesis. My goals for the presentation are to make you familiar with all of these conditions so that, number one, you can make an early diagnosis and initiate a prompt referral to an appropriate orthopedic surgeon, but also some of you might find the information a little bit too much, but I do think as primary care physicians, your patients expect you to be able to counsel them in some way about these conditions and help them navigate what a pediatric orthopedic specialist might tell them about the various treatments. So for some of you, this will be not enough information. For others, maybe too much. But I hope you find that at the end of the day, you'll a little better knowledge of some of these conditions. So this is just a 30,000-foot view of most of these topics. And spinal deformity can occur as an isolated condition or it can be associated with other conditions. But in your practice, you should be always looking for spinal deformities on every well-child visit. And you do this merely by looking for body asymmetries. You can see in this youngster that the arm is further away from the thorax on one side than the other side. You see some asymmetry in the chest wall. You see the scapula in this case is a little more prominent on one side than the other. The waist appears asymmetrical. But the way that you always look for spinal deformities, and I would encourage you to include this in every single well-child visit, is just have the patient bend forward and look for the rotational prominence that you see on the chest. You can look at the child from the back, as you see here. My own personal preference is to view the child from the front. And you see that in this girl's case, her right hemithorax is more prominent. And this is because of the rotation that accompanies any spinal deformity. You can see the diagram on the right. As the spine rotates, the ribs become more prominent. It's not that they're bigger, it's just that they're more prominent because of the rotation. And this is the test you should do in every whale child examination in your practice. It takes 5 seconds. I also like to look at the children in 3 different positions, as you can see in this youngster's superimposed brassiere line. Some flexion to look at the upper thorax, a little more flexion to look at the thoracolumbar region, and then more significant flexion to look at the lumbar spine. When you're looking at the spine, you should also quickly look at it from the side. We'll come back to the kyphotic deformity later, but the diagram shows what a normal child's spine should look like in a forward bending position. It's a very smooth curvature as opposed to the youngster in the lower left, where you see the prominence is very sharp and angular. You should just learn to distinguish between these two, normal on the right, abnormal on the left. So scoliosis just means curvature of the spine. And when you see a child who has some curvature, one of the more critical points in diagnosis is this structural or non-structural. If it's non-structural, once the primary problem is treated, the scoliosis goes away. For most of our presentations, we'll be talking about structural causes. But just to show you some examples, this is a teenage boy that I saw with this terrible scoliosis that anyone could certainly recognize. Looks terrible, very abnormal. And his physical exam was also grossly abnormal, that he had a positive straight leg raising test on the left side and some weakness of his lumbar 5 nerve root manifest by a weak extensor hallucis longus. He got an MRI. You can see this is a large disc herniation. This is 1 day after I treated the disc herniation. All of his symptoms were gone. His scoliosis is resolving. And so this is just an example of a disc herniation causing a scoliosis. This is a non-structural cause. Once you take away the problem, it goes away. Here's a much simpler thing you might see in practice. This is a little girl who presents with a curvature. She has body asymmetry, as you can see on the left, but you notice that her pelvis is not level. One leg appears to be shorter than the other. And by putting a simple 1 centimeter block under her left foot, the scoliosis goes away. And this is simply treated by a shoe insert, another non-structural cause. This is a teenage girl who was actually quite petite, but always told me that her abdomen was always bloated, and she has a very mild scoliosis on X-ray, but in fact, she has an ovarian cyst, which causes a secondary scoliosis. And you can see, here's another patient who came in with a curvature of the spine, a little bit atypical, and the patient had on X-ray an absent pedicle, and this was a tumor in the spine, as you can see in the lower right. And once the tumor was treated, the scoliosis went away. So those are non-structural things. So you should always be looking, is there something else going on here that you should be suspicious about? But for the remainder of the talk, we'll be talking about more common things that you see in a practice. And the most common of which is idiopathic scoliosis for which we don't know the cause. On the lower right, you can see congenital problem with spinal abnormalities. You can see in the further lower right, a child with cerebral palsy. And the upper right, a child with neurofibromatosis. These are other conditions which we'll briefly touch upon. But the most common type of scoliosis is called idiopathic. And idiopathic scoliosis is one for which we don't know the etiology. These are otherwise normal children who present to you with a spinal deformity. And in 2024, these are divided into 2 groups. Older than 10 years of age, which is called late onset, and earlier than 10 years of age, which is called earlier onset. And I'll make the distinction of why this is important in just a little bit as we talk about each of these individually. Once again, idiopathic scoliosis is a diagnosis of exclusion. You've done a complete history, you've done a physical exam, which is completely normal. And I'll emphasize that a complete physical exam includes a complete neurologic examination, including abdominal reflexes and gag reflexes. The abdominal reflex, I'll comment briefly. Sometimes this is absent, particularly in children who are very ticklish or always moving around. But what I consider important is an asymmetrical abdominal reflex, positive one side, absent on the other side, and an absent gag reflex. These are possibly indicative of intraspinal pathology, but idiopathic scoliosis is a diagnosis of exclusion. A normal child. And again, this emphasizes the fact that you're doing your normal, complete, thorough past medical history, birth history, appropriate milestones, that they walked by 18 months of age independently, et cetera, et cetera. And again, you've done a complete skin, spine, lower extremity, upper extremity examination, and you found nothing other than the spinal deformity. Here are some just skin manifestations that should get your interest to say maybe this curvature is not normal, such as cafe au lait spots, axillary freckles, these large lesions like hair tufts in the lower spine, or fatty infiltrations, bruising or trauma situation that might make you think of some other inciting cause rather than idiopathic scoliosis. I also put my hands on the chest and check chest excursion. And again, the reflexes we talked about, abdominal and gag reflexes, are very important to check because they could be the sign of some underlying neurologic problem or a Chiari malformation that the child may have that was the underlying cause of scoliosis. So again, a complete examination. And then you're left with a child who has a rotational deformity, as you can see on the forward bend test, a positive X-ray, but you don't have a cause. So therefore, you're left with idiopathic diagnosis. Now, this has been a study of my whole life studying idiopathic scoliosis, and there's really good evidence that there is the genetic cause, that this does run in families. It's probably polygenic. But there's no question that many of these patients will have a positive family history. But we don't know there's no specific gene, as I alluded to. It's probably polygenic. And just because one member of a family has it doesn't mean that their siblings will have it or that their children will have it. But it's important to note that it does run in families. Now, we talked about this distinction of age 10 being the adolescent onset. And, there's nothing magical about the 10th birthday. It just so happens that's how people classify it. But this is a patient of mine who was first seen at age 16, and we happen to have a chest X-ray at age 5 showing it wasn't present at age 5. So it wasn't something that was there at a very early age, but this 10-year age dividing point between early onset and late onset is purely arbitrary. As I mentioned before, you make the diagnosis by the forward bend test and looking for the rotational asymmetries, as you can see in the young lady we've shown over and over again in the center of this slide. But the reason this is important is it's not the curve that causes the functional problems, it's the spinal rotation that causes all of the potential problems the patient may have going forward in life, including pulmonary problems, its effect on back pain, psychosocial aspects of having a spinal deformity. So it's the rotation which tips you off to the diagnosis, which is actually the most important component of the deformity. And even when you see this deformity grossly on the forward bend test, what you see on the clinical exam doesn't necessarily correlate with the X-ray. So you can see a large rotational prominence, but the curve may be small, or you can see a curve that looks actually quite well balanced on the young lady on your left, but she has quite a severe curve. So it's not a direct correlation between the amount of rotation you see on the clinical exam and the x-ray. Here's a youngster that has a very large prominence that was detected by his pediatrician, but yet has a very small curvature. Still needs to be evaluated and monitored, but again, just to show you that the size of the rotation, amount of rotation doesn't necessarily correlate with the deformity you see on x-ray. And also remember, this is just rotational deformity, because some parents come in noting that they think their child's muscles are bigger on one side, which is not true at all. It's just the rotation makes the soft tissues stick out on that side more than the other. So we measure the x-rays by what's called the Cobb angle, and what you're doing is measuring the greatest curve that you can measure by the upper end line you can see here in the lower end line. So you're getting the maximal curvature of the spine. In this case, it's 32 degrees. But in the scoliosis world, we say to have a diagnosis of scoliosis, you have to have at least a 10-degree curve to qualify. Anything less than 10, we don't diagnose as scoliosis. And actually, in the real world, anything less than 20 is not very significant, but 10 degrees is the threshold to make the diagnosis. On your x-ray, you're also ruling out other causes. You're looking for congenital spine abnormalities, rib abnormalities. So in the face of a normal physical exam, you want to have a normal x-ray exam other than the curvature of the spine, no congenital abnormalities. So scoliosis, idiopathic scoliosis, those children are diagnosed over 10 years of age, is very common. 2 to 3% of the population of the world will have a curvature of over 10 degrees. That's hundreds of millions of people. But as the curve gets larger, you can see the numbers of patients dramatically drop. So scoliosis per se is very common, but significant scoliosis is very uncommon. And in a practice like mine of scoliosis patients, most of the patients will be girls because the more significant curves are girls. But when you look at the threshold of 10 degrees, scoliosis is equally common in boys and girls. But for some unknown reason, girls are the ones that tend to get worse. So if you see a curve of over 30 degrees, it'll be girls 10 to 1. Now, as I've kind of alluded to, scoliosis is extremely common, with 2 to 3% of the population having it, but very few patients of the universe of patients with scoliosis will actually need treatment. Less than 1% of the patients identified with scoliosis will actually need treatment. And so it's important not to unnecessarily alarm parents with the diagnosis unless the curve is significant. So let's talk a little bit about what happens to patients. What's the worst that can happen? We'll talk about natural history because as a pediatric orthopedic surgeon treating scoliosis, my goal is to prevent adverse natural history. So what are we trying to prevent? Well, when I was a young trainee in the 1970s, the literature on scoliosis painted a very grim picture. And pediatricians like yourselves were taught, as were orthopedic surgeons, that if you had scoliosis, you could become paralyzed, disabled, you'd probably not get married, and you probably shouldn't have children. And this poor literature, unfortunately, impacted teaching textbooks for the next 40 to 50 years. And I want to dispel all of these rumors with you this morning. And my whole life has been based on studying the natural history of this condition. And these are 5 studies out of Iowa City, which outline the natural history of a large group of patients who never had treatment. And for those of you who are interested, this was published in the Journal of the American Medical Association in 2003. And this is the lifetime natural history of a large group of patients, untreated, followed for their entire life. And while there are flaws with any study like this, I would posit to you today that probably there won't be any other studies like this coming forward in the literature. And even for its shortcomings, I would say to you that the facts that I talked to you about today probably will be proven to be reliable for a very long time. So this was a group of 223 patients, excuse me, which I had the privilege of following up for over 50 years. Their average age at the final outlook or final evaluation was senior citizens. Their average age was 66 years of age. Now, this is something you should understand, is that idiopathic scoliosis, normal scoliosis, has 4 distinct curve patterns. The most dominant curve pattern is the thoracic curve pattern, and 95% of these curves should be to the right. If you see a left thoracic curve in a child 10 to 15 years of age where you're picking up scoliosis, that is a warning sign that that child may not have idiopathic scoliosis, and a child needs to be evaluated further, either by yourself with an MRI or referring it to a specialist immediately. The other curve patterns are where the apex of the curve is in the lumbar spine, which can be right or left. Thoracolumbar curves, where the apex is at the thoracolumbar junction, T11-12, that can also be right or left. And double major curves, like an S curve. These two the thoracic curve should be to the right, the lumbar curve to the left. And if you see the opposite, that should raise your attention that this is abnormal. And again, the left thoracic curve is a red flag, and you should evaluate that further. Now, as a pediatric orthopedic surgeon seeing these patients, I'm always want to know and advise my patients, will the curve get worse? Because if it gets worse, then I'm worried about future problems. So let's talk a little bit about curve progression. We'll talk about backache, pulmonary effects, psychosocial, and the effects of and on pregnancy. So the worry for any parent is that the child's curve will get worse. This then may lead to pulmonary problems. It may cause them pain as an adult. They will have an increasing spinal deformity, which may have secondary psychosocial effects. So in talking about risks of progression, what I am looking at is where is the patient on their growth curve? Because growth potential is the enemy for a young child with scoliosis. All of you as practicing pediatricians know this typical growth velocity curve, that children grow very rapidly in the first 3 to 5 years of life, though the velocity is always slowing down, then they kind of grow at a steady rate until the adolescent growth spurt, which occurs 2 years earlier in girls than in boys. Then the adolescent growth spurt occurs until they reach maturity. It's important in this diagram to recognize that the first 5 years of life, the growth is much more rapid than during the adolescent growth spurt. The actual velocity of growth is much greater in the early years than it is during the teenage growth spurt. And this has a big impact on things like lung development and pulmonary function, as we'll talk about as the lecture progresses. So the top line here is the equivalent of the teenage growth spurt. And you all know this, but the teenage growth spurt for a young lady is heralded by the onset of breast development. You can see that by a time that a Caucasian female has her first menstrual period, you're already on the downhill slope of the growth spurt, the teenage growth spurt. So the velocity of growth is already decreasing by the time a young girl has had her first period. When you talk about males, and particularly Caucasian males, by the time a young man has enough hair to shave on a regular basis, they're almost already through with that teenage growth spurt. So as a pediatric orthopedic surgeon seeing children with scoliosis, I'm always concerned about where they are on the teenage growth spurt. So we're looking at markers of growth. And in my world in 2024, we tend to use the digital skeletal age as measured by the hand as a much more accurate assessment of where the child is on the teenage growth spurt. And we look at various other growth centers, which aren't important for this lecture, but And in orthopedics, some people use the growth center at the elbow. I happen to use the fingers. There's a growth center at the triradiate cartilage in the pelvis. And there's the ossification of the iliac crest, which are different methods which people use to try and give them a better handle of where the patient they're seeing in front of them today is on the adolescent growth spurt. And just as a gross prediction, you can see that small curves on the diagram here, a curve less than 20 degrees in a mature child, and we arbitrarily say this is a 16-year-old, has no chance of getting worse as an adult. If the curve is less than 30 degrees in a mature child, also very good prognosis for the future that it won't get worse. Once the curve is over 30 degrees, then we worry a little bit more about that child, even when they reach maturity, as you can see here, that even after a mature child with a curve between 30 and 40, it can progress, 30% of them do. And certainly in a curve over 40 degrees, we worry significantly and always follow those children on a routine basis because those curves can get worse. What about back pain? As I mentioned to you, when I was a young resident, the thinking was these patients are going to be disabled by backache. Well, I think all of you who treat any adolescents or maybe some adults know that at least 50% of adults have some backache during an average year, and 15% of adults have back pain that lasts more than 2 weeks. And there's very good evidence out of Scandinavia that 85% of teenage children will have backache at some time during their teenage years. So back pain is a pretty common problem in teens. When you look at these scoliosis patients, yes, they did have more back pain that controls over a lifetime, but in fact, their ability to work and have and normal activities of daily living is the same as non-scoliosis patients. So it's important to assure your patients and their families that their children do not need to expect a lifetime of back pain, and they will be able to function as normal adults regardless. What about lung function? Well, you all would know as well as I do that a curve in your lower back is not going to affect your pulmonary function. But a large thoracic curve, such as you see in the X-ray here, there is a direct correlation between increasing curve severity and decreasing pulmonary function as measured by vital capacity and FEV1. But it takes a very severe curve to truly interfere with a youngster's pulmonary function, a curve that approaches 80 to 100 degrees. So if you're seeing your children and you're screening, just to reassure your families that this is not going to be a problem and they need to have a prompt treatment so that this is prevented. So what about, do they die from scoliosis as I was taught when I was a young resident? And the answer is no. The only person that could possibly die from the adolescent type, the children over 10 years of age, are those that have very, very severe thoracic curves that are left untreated. These patients could get significant compromised, decreased vital capacity, and restrictive lung disease. But adolescent patients do not die from idiopathic scoliosis. What about psychosocial effects? Well, it's very clear that scoliosis does cause deformity. Deformity in children causes, in some cases, some psychosocial disturbance. Children are bothered by the deformity in many cases. In our long-term follow-up, even though these patients had done well for a lifetime, they all expressed some dissatisfaction with their body appearance. And what I would say, there was no correlation between what their X-ray looked like and how satisfied or dissatisfied they were with their body image. These patients were seen in years when no treatment was available, and the one thing they did say to me is that they wished they had choices when they were younger, but obviously none were available. Here's two patients. The man on your left is one of our natural history patients, very severe deformity, But he responded with his questionnaire that the curvature never bothered him. He was a wrestling coach and had a very normal life. The lady on your left, who had also a significant deformity, responded that she would always wear clothing that would hide the deformity because she was bothered by it her entire life. And these are some more modern papers which basically shows all scoliosis patients, whether they're treated successfully by a brace or wound up having surgery or had no treatment at all, were generally very concerned about their body appearance. And so I do think that the modern teenager may have some psychosocial disturbances associated with their deformity, and these should not be ignored. It's, social media puts tremendous pressure on children, and how they perceive themselves is something that they often don't discuss with their parents or even their pediatrician, or even to someone like me who's actually seeing them specifically for the problem. What about pregnancy experiences? Another misconception. These patients all have normal reproductive experiences as adults. So you need to assure your parents that their young daughters, regardless of even if they need treatment, they will have normal reproductive experiences as adults. They can have children, they can deliver vaginally, they can have epidural anesthesia. Their reproductive experiences are normal, and they should not be worried about that. So why do we treat scoliosis? Well, we treat it because it is a deformity. Some of the children do have psychosocial disturbances, but our goal for very severe curves is to stop progression, to prevent back pain from keeping the curve smaller so that we hopefully can prevent back pain, and in thoracic curves to prevent it getting bad enough that it may cause pulmonary compromise. Now, what are some warning signs on your physical examination? And these are things as you evaluate patients at your well child checks looking for spinal deformity you should be aware of. Does the child have an unusual curve pattern? We talked about the 4 curve patterns which are routine for scoliosis. Be aware of the left thoracic curve. It's indicative the patient needs a further workup. Also, if you see any kyphosis, that's also indicative you need to work the patient up further. If the child comes to you at under 10 years of age, this is considered a different condition called early onset. That requires a further workup. If you find any abnormality on your physical exam, a neurologic deficit, asymmetrical abdominal reflex, this requires further workup. Rapid progression, if you happen to be following a child and you're doing some follow-up prior to referral, if the curve progresses more than a degree of month, then this is considered rapid progression. And the one that we see more and more of is pain. And I'll go over each of these. Remember, scoliosis has 4 predictable curve patterns. Here's 2 red flags. The child's under age 10. She has a long left thoracic curve, and her workup showed a Chiari malformation and syrinx. Here's a very subtle one. This girl is 9 + 5, so just under the 10-year threshold. But notice she has a very small upper left thoracic curve, but this is atypical. This triggered a workup, which is an MRI. She has a very severe syrinx and Chiari malformation, which required treatment. Here's another 7-year-old with an atypical curve, under to age 10, atypical curve, and she also has a syrinx. Here's a left thoracic curve in a 7-year-old, and notice she also has a syrinx. I show you this patient who's a 2-year-old who had a left thoracic curve, had an appropriate workup, had a Chiari malformation and syrinx. She was treated by the neurosurgeon, and noticed that the treatment caused resolution, just showing cause and effect, that Chiari malformations and syrinx do cause scoliosis. And once the primary cause is detected, the scoliosis goes away. And here's another one, is a 6-year-old. It's a right thoracic curve, so it's not atypical, but it's under age 10, so that warrants a further workup. But also there's no rotation. This was just picked up on an X-ray because of the deformity. The child had no rotation on forward bend test, and another syrinx and Chiari malformation, which, by the way, is the most common abnormality we see in these atypical curves. Now, I mentioned the issue of pain because back pain is quite common, particularly in teenagers nowadays. What do I consider significant pain? Pain that disturbs sleep, wakes them up from sleep, removes them from pleasurable activities, or frequent school absences. All of these get my attention, and I always further work these up, starting with an MRI. I mentioned kyphosis again because you can see this patient has a very typical curve, but on the sagittal view, the patient is kyphotic, which is abnormal for scoliosis, and this patient also Chiari malformation and syrinx. And lastly, I think this is a 13-year-old left thoracic curve. We do occasionally find tumors as this child with an astrocytoma. So the workup, if you're going to initiate it, always starts with a cervical, thoracic, and lumbar MRI. And lastly, this is a very sad case of a child who I actually saw on the right X-ray when she was 19 years old. But this was her X-ray at age 9, and her parents were very big believers in alternative medicine. So if she were seen in your clinic today, she would get an MRI because she's early onset under age 10. But this was her initial X-ray. She was also a little kyphotic. No treatment was done, and she turned out to have a Chiari malformation and syrinx, all of which could have been prevented by just simple recognition that this is early onset scoliosis and pursuing the workup. So treatment for scoliosis, I told you, I'll just talk about this briefly as this is done by orthopedic surgeons, is we're trying to lessen deformity, prevent it from needing surgery, keeping the spinal curve as small as possible, hopefully preventing back pain, and hopefully preventing the need for surgery or any compromise in pulmonary function. So the common treatment for patients with curves over 20 and less than 40 is a brace. And they wear this while they're skeletally immature, while they're in their adolescent growth spurt. This is the type of brace that's most commonly used today. Children wear it about 14 to 18 hours a day, of which sleeping counts. And this is the research to support this. This is our research in the New England Journal supported by the NIH, which showed that braces do work to prevent the need for surgery. Level 1 evidence that if a curve is over 20 degrees in a skeletally immature patient, that braces do prevent the need for surgery. And this also is meant to show that they have to wear it. If a child wore the brace more than 13 hours a day, they had a 90% chance of avoiding surgery. And this is important for you to know if any of your patients are under brace treatment, just to provide encouragement to the family and the child that braces do work, and your goal here is to prevent the need for surgery. To know about it, there's other exercises called scoliosis-specific exercises, and in your region of the country, there may be certified Schroth therapists. These are scoliosis-specific exercises. There is no scientific proof that they are effective, but I do believe that they have merit, and I'm cooperating with the physical therapist to develop a trial to show if they do improve the prognosis. But I am 100% supportive of these exercises, but they should be done by a certified Schroth therapist. Just for information, we continue the bracing until the child reaches the end of their adolescent growth spurt. When do we do surgery? We do surgery if the brace doesn't work, and for children who are not eligible for a brace. That is a curve over 50 degrees, which braces don't work. If a curve gets worse after maturity, and sometimes we don't do surgery for small curves, even if the patient is unhappy about it. We encourage psychological counseling, exercises, but it is important to help counsel your children who are unsatisfied with their appearance. And I do believe Schroth therapy and learning to deal with it is important, and also continuing to follow them just in case the curve does get worse. Surgery is usually by fusion and instrumentation to correct the curvature. And then lastly, we'll talk about early onset. We've kind of alluded to a lot of this already, but why is this more important than the adolescent group? Because these patients, if the curve occurs very early in life, the first 3 to 5 years, these children indeed can die from their scoliosis. This is a rare condition. It's 1% of all children with scoliosis. In this case, they do present often with left-sided curves. And again, you need to look for other problems such as hip dysplasia, heart disease, and various other conditions. But when you're seeing your newborns and your toddlers, please look for this because it's important to pick it up early. And this is mortality. You can see on the right that the adolescent group mortality matches expected mortality for their age. On the left, these are children who have scoliosis diagnosed in the first 3 years of life. Mortality far exceeds expected mortality. So these children can die from their scoliosis. Why? Because just like the typical growth curve as we see in the upper right, the fast-growing years of first 3 to 5 years, that's the same is true with your spine. You achieve 2/3 of your final sitting height, in other words, the length of your spine by age 5. So anything that affects the length of your spine and anything that affects the chest wall will affect the development of the alveoli and pulmonary function. You all know that your alveoli continue to proliferate in the first 4 years of life and then taper off by age 8. So anything that affects the length of the spine or the chest cavity itself can impair the development of the alveoli and also their proliferation and their oxygen carrying capacity. That's why early onset scoliosis is very different than late onset scoliosis. And again, emphasizing that pulmonary development in the first 8 years of life is critical. So that's why this spinal deformity or any spinal deformity and any other disorder that occurs in the first 3 to 5 years of life can have a profound impact on pulmonary function and eventually can lead to respiratory death, severe pulmonary compromise. So I won't go over these in detail, but I think you are all quite well versed in pulmonary physiology and you get the gist of this, that anything that affects the length of the spine or the chest wall can impact pulmonary function. And here's just to show you an example. This is a 1-year, 10-month-old at 32-degree curve. MRI was negative, looking for other causes, so it was idiopathic. The family refused treatment. They came back a year later. The curves are getting a little worse. They still refused treatment. And here's the child at age 6, and here's the child at age 9 years when the family finally consented to surgery. And you could see what a disastrous effect this deformity would have on pulmonary function. Again, any early onset patient, this is repetitive, I know, but it warrants emphasis. Any child you see with a scoliosis deformity under age 10 warrants an MRI. Now, if you're seeing a 1 or 2-year-old, obviously an MRI would require a general anesthesia. So if the exam is otherwise normal, I might delay it a little bit if I feel that this child is otherwise completely normal. I might delay doing the MRI till it could be done with medication sedation as opposed to general anesthesia, but they will need it to rule out any intraspinal pathology. Now, the treatment of early onset scoliosis mirrors a little bit of the later onset, but the treatment in 2024 is either by casting the deformity or bracing it. And the goal here is either to hopefully have the curve resolve, but at least delay the need for surgery. And you particularly want to delay it in children these age because of what we talked about pulmonary function. So casting for spinal deformities has been around for well over 100 years. These are some early pictures of children being casted. And this is what a modern day cast would look for a child with early onset scoliosis. This is a 2-year-old. Unfortunately, the casting is done under general anesthesia every 2 to 3 months. So these children have a general anesthetic every 2 to 3 months. So as you can imagine, this is quite a big inconvenience. There's certain risk for the child and the family. And hygienes, particularly in warmer climates, is a bit of a problem with a cast. Now, I'm not saying to you that casting works or is the best treatment. In fact, in my lifetime as a pediatric orthopedic surgeon, we abandoned casting because we weren't sure it worked. But this article came out in 2005 from a very wonderful woman in Great Britain who herself had early onset scoliosis, and she reported a 70% correction for early onset scoliosis. These are normal children, no syndromes, they're not developmental delay, no other causes. She reported a 70% cure rate. Well, that got the attention of everybody in the age of the internet. Parents certainly know about it. And it made pediatric orthopedic surgeons immediately recommend casting for all their patients. And as a researcher myself, no study has ever shown the same degree of success that was represented in that 2005 paper. But nonetheless, casting remains the primary treatment in the minds of parents and most pediatric orthopedic surgeons. But to again reiterate this, no study since has achieved those same results, including our own. Now, new evidence has come out, which is, I think, important for you to understand as pediatricians counseling your family. In 2017, the Food and Drug Administration came out with a report that said repetitive anesthetics in children under 3 years of age or prolonged anesthesia in the same group of patients can negatively affect brain development. And it seems what they imply here and what's turned out to be this negative brain development manifests itself as impairment in executive function in the teenage years. So the American Society of Anesthesiologists said, well, it's not really known whether it's the anesthesia drug or other factors that's responsible for these findings. But as someone who treats early onset scoliosis, and if I were a parent of a child with early onset scoliosis, I'd certainly want to take this factor in mind as I make decisions about my child. So the other alternative to casting, because these children certainly do need treatment because you want to prevent the consequences of, particularly disastrous consequences of progression leading to pulmonary compromise, the other alternative is bracing. And bracing also has been widely used, but once again, there is no agreement the success with bracing is any better than casting. So here's some examples. This is a child with a very impressive curve that I treated by casting. And here's the child with complete resolution of the curve by 6. Here's another child that I treated with a brace. Complete resolution of the curve, pretty impressive. So it leads you to the impression that casts work, braces work. And here's another child that I saw whose family said, we don't want to cast, or other child that cast, we couldn't stand it. We'll wait until the child needs surgery. So this patient never had any treatment. And you can see here's the patient with no treatment, and the curve has gotten better on its own. So what I hope this exemplifies is that we don't know the natural history of these curves. Some do resolve, some do respond to casting, some do respond to bracing, but what we don't know and what parents need to know, is there evidence to support one or the other? Many pediatric orthopedic surgeons who refer your patients to will have a strong bias one way or the other, but I'm here to tell you that there is no proof that one is better than the other. And this needs to be a shared decision-making between your parents and the pediatric orthopedic surgeon who's providing treatment. And we have a clinical trial ongoing in the United States comparing these two treatments. And I think that that'll be what's needed in the future, because neither of these treatments has proven to be the answer for every child. And again, each treatment always has risk versus benefits. So when these curves progress despite bracing or casting, then we go to growth preservation surgery. Just to know a little bit about this, because some of your patients that you're following will be undergoing this. And we're trying to allow the curve to be stabilized until these patients get to their teenage years and then do definitive surgery. What we do is we place rods. We only fuse the top and the bottom of these constructs, and then we have a mechanism to allow the children to grow. This is a more traditional growing rod. You can see the fixation points at the top and bottom. You can see the rods. In this case, there's a lengthening tube, and we take the patient to the operating room every 6 months. Here's the patient. The curve progresses. They failed casting, and the parents don't want another cast. They don't want a brace. Here's the rods in place, but they have to go to the operating room, a general anesthetic, every 6 months until they reach maturity. In 2014, magnetic growing rods came about, and some of your patients may have these, or some of the centers where you refer patients to may be using these. They were developed. They're extremely expensive. They're $20,000 per rod. They're placed once, and you can argue that they're less expensive over time. But what happens is these rods can be lengthened in the clinic by a magnet every 3 to 4 months, so the child does not need a repetitive anesthetic. So while they're extremely expensive to put in, many healthcare systems, like the British healthcare system, approve their use because over time they become less expensive because the child needs less surgery. I would argue that these are extremely expensive. You can see here's the mechanism by which we lengthen the rods in the clinic, and here's an example of a child of mine, and you can see how much the rods have lengthened over 1 year time. So the goal here is to delay definitive surgery while the lungs grow, while the rest of the patient grows, and try and get them to their teen years when you would do definitive surgery. Important to know for your children who are undergoing growing rod treatment in a center near you is that the complication rates are very high. Whether it's magnetic or traditional growing rods, 30 to 50% of patients have a complication and may need additional surgical intervention. And as you counsel patients of yours who are undergoing these treatments at centers that you've referred them to, what's important to realize that I, as a treating physician, counsel parents that I'd like to prolong casting or bracing as long as possible, because once we start this growing rod train, you can't get off of it. You can't get off of it until the child matures and they have a definitive surgery. And every child, the family needs to expect a 30 to 50% complication rate, unexpected surgeries. It is a journey, and it's important that they realize what they're getting into and to be supportive of their journey. Now let's just briefly talk about other spine conditions you'll see. Congenital spine deformities come in basically 3 types: failure of formation. These are hemivertebrae; failure of segmentation, which are a fusion between vertebrae; or mixed. And these can cause all kinds of deformities: scoliosis, kyphosis, kyphoscoliosis, and they all have a variable natural history. The most severe ones you will see early when you look at a child in the newborn nursery or in the first 3 years of life. These are always significant. Those that you see later on that is incidentally found on a chest x-ray are often of less significance and cause less severe deformity. And these all relate to differentials in growth on one side versus the other. So you can see in this child who had a lumbosacral 2 hemivertebrae, there's more growth on the left side of the spine than the other side. This is going to obviously lead to a deformity. Hemivertebrae, which is failure of formation, come in all different shapes and sizes. And again, excuse me, it's just important to recognize these and then there's failures of segmentation, which are fusions. Bars, some of you will know Klippel-Feil syndrome, which is fusions in the cervical spine. You're going to see these on an X-ray, and you're going to refer all of these children. What's important for you as pediatricians to know is when you pick up a congenital spine deformity, every child should have a renal ultrasound, because 20% of children with congenital spine abnormalities will have a renal abnormality, most common of which is an absent kidney. So if you detect them, I think the very least you should do is a renal ultrasound. And then the other thing is 10% of these children will have cardiac anomalies, and you can choose to get a echocardiogram if you feel it's justified. But the one thing you need to pick up is any renal abnormalities. And I think you all would see children with Vactral syndrome or what used to be called Vater syndrome, and that helps you put this association of congenital spine abnormalities with renal abnormalities. So getting a renal ultrasound should be part of your workup in addition to appropriate referral. Here's a pretty benign looking hemivertebrae. This child I saw in the newborn nursery when it was picked up. You can also see a rib fusion on the opposite side. I told the family this is a very bad combination because you have no growth on one side because of the rib fusion, and you have an extra growth center on the opposite side. This will for certain get worse, and you need to see me on a regular basis. They didn't return till the child was 14 and partially paralyzed as the curve got significantly worse. And you can see what happened to that child is the spinal cord draped over and caught impingement. So these are very dangerous, and he required surgery. But what's important for you as pediatricians to know is braces are never used for this condition. They either need nothing but observation, or they eventually will need surgery by a qualified pediatric orthopedic surgeons. But again, I think your role as a pediatrician is to make the diagnosis, get the renal ultrasound, and make the referral. Surgery is indicated at any age for these children. It's indicated if the curve is severe or if the curve gets worse. And just to show you some modern surgical techniques has allowed us to do shorter fusions than we used to do in the old day. This is a child with a hemivertebrae. It was progressive, and then I was able to remove. So here's a very short fusion. This child goes on to have it's a big surgery, but it's a minimal impact on their ultimate function for life. So these can be treated quite well in 2024. Neuromuscular scoliosis, any child with a neuromuscular disease has a high risk of scoliosis. 25% of children with cerebral palsy, 60% of children with myelodysplasia, spinal muscle atrophy, very high incidence, pre-direct ataxia, very high. Duchenne muscular dystrophy was very high, and I'll come back to that in a second. And any child who sustains a traumatic paraplegia or quadriplegia under age 10 has a 90 to 100% chance of getting a spinal deformity. Now, what's the impact of modern treatments? Some of you who have spinal muscle atrophy patients in your clinic who are either getting genetic treatments or nusinersen, Spinraza injections. This has not changed the course of scoliosis in these patients. It may have improved their function, but it has not changed their need for treatment of spinal deformity. Duchenne muscular dystrophy, on the other hand, the use of steroids, which stabilizes the basement membrane, has made a dramatic impact. In the past, 90% of patients with Duchenne muscular dystrophy in the United States came to surgery for their progressive curves. I would say with the use of steroids, very few patients now require surgical treatment for their scoliosis, but they also have obviously the extensive complications that can be associated with high dosage of steroids. So spinal curvatures in neuromuscular cases are very, very different. They're awfully very long, and they often have kyphosis because the children have poor trunk control. And what's important to realize is that you could have a 70-degree curve in a child with a idiopathic scoliosis. It's very different. A 70-degree curve in a neuromuscular patient will have a much more profound impact on their quality of life and their pulmonary function. Many of these children this is a boy with SMA on your right, have a profound loss of function. They lose the ability to sit. They sometimes lose the ability to use their hands. And obviously, as we mentioned, a 70-degree curve in a neuromuscular patient like this has a much more profound effect than an idiopathic patient. Decisions here are made on quality of life. This is not heroic surgery, but it's does the deformity affect their ability to ambulate? Does it affect their ability to use their hands? Does it affect their ability to sit in a wheelchair? And these are quality of life issues which we discuss with a family before making treatment decisions. The various wheelchair supports we use or braces don't stop the curve from progressing. This is a brace that's commonly used like a clamshell. We use these brace devices or the wheelchair modifications to help sit the child better in a wheelchair, but they don't prevent curve progression. And we only use braces during the sitting time for children. We don't have them use it at night. Our goal here is to delay surgery as long as possible to, again, let them grow, let their pulmonary function stabilize as long as possible. And this is, how a cerebral palsy boy with profound impact, he was losing his ability to sit. His quality of life was suffering. He couldn't use his hands anymore and had a profound pelvic obliquity. And this is his post-surgical. And you can see how this profoundly affected and improved his quality of life. Even though he couldn't express it, his parents express it by his happiness level, his less effect by pulmonary infections, his feeding better through his feeding tube, etc. And again, here's pre and post-op. And here's a child with severe spinal SMA and only had a 29% vital capacity. And so the child is going to die if you don't do something. This is his pre-op film, his surgical correction. It's not earth-shaking, but he died at age 34. He was a computer program, and he got another 25 or 30 years out of life, and this improved his quality of life. Syndromic patients, any child you have with a syndrome, there are many syndromes who have scoliosis associated with it, and you should always look for it. No fibromatosis, Marfan, Prader-Willi, Vacteral, Noonan's, Williams, Smith-Magenis, and many, many more. Many syndromes are associated with scoliosis. These are all treated similar to the idiopathic patients we talked about by the use of brace, and if the curve progresses to a significant degree, then by surgery. But it's important to recognize the association. All of the treatment decisions in syndromic patients are also based on quality of life. Will it impact survival? Do they have pain? Are they disabled? Now, kyphosis is our next topic. Just to note that the normal sagittal curve of the spine, children normally have lordosis in their cervical spine. The thoracic kyphosis, as measured T2 to T12, is roughly between 10 and 45 degrees of kyphosis. The thoracolumbar junction, T10 to L3, should be straight. And the lumbar spine has lordosis, which usually is 30 degrees more than the thoracic kyphosis. So these are just normal parameters of sagittal balance. If you take x-rays or refer patients in x-rays to in your practice, make sure that the x-rays are standardized. We do our x-rays, as you can see the child positioned on the illustrations on the left, to keep the arms somewhat out of the way and get them standing up straight. So standardization of x-rays is important. As we mentioned earlier, the most common kyphosis deformity is just poor posture. And when a child who comes in with kyphosis has poor posture, When they forward bend, as you can see in the cartoon, they should still have a very smooth curvature to their spine. Postural kyphosis, again, the most common thing you see, is treated by exercises, stretching, laying over a foam roller, particularly back hyperextension exercises, swimming, things that the child can take control of if they want to. Of the structural kyphosis we see, the most common that we see in our practice is Scheuermann's kyphosis. And Scheuermann was a Danish radiologist who described this in 1920. And you make the diagnosis of Scheuermann's kyphosis by wedging of at least 3 successive vertebrae. So on a lateral film, standing film of the spine, you will see this wedging of vertebrae and irregularities of the end plates, which we call Schmorl's node. So this is how you make the diagnosis via X-ray. Scheuermann's kyphosis is also quite common. I would say about 5% of the population has it. These children show up to a pediatric practice similar to the scoliosis patients in the 10 to 13 age range, and you should be looking for it on your screening exams, just like you look for scoliosis. And what you will see that's an abnormality is this kyphosis, the sharp angular kyphosis, either in the thoracic or the thoracolumbar junction. Some of these children will come into you with back pain, which is usually at the apex of the kyphosis. It's at the apex of the kyphosis, apologize. And it is relieved by rest, is prolonged by standing or heavy physical activity. 1/3 of these children will have a scoliosis associated with it. They get secondary tight pectoral muscles. And this is what a Scheuermann's patient looks for. It looks like compared to what you might see in the normal. Here's 2 brothers with it. There's only one natural history. This was a study we did at Iowa a long time ago. These children, because of their large chest, actually have greater than normal pulmonary function. But if the curve gets very severe, they can get restrictive lung disease. These children do have back pain. Many of them are unhappy with how they look. And if the curve gets very severe, it can also have restrictive lung disease, but most do very well. As I mentioned, the apex could be at the thoracic spine, so these children look like barrel-chested individuals, but when the apex is at the thoracolumbar junction, which should be straight, they cosmetically look very unsightly and are often very unhappy. We use braces in these children, just like scoliosis, to try and prevent it from getting worse. But unlike scoliosis, bracing in the Scheuermann's population, it has very poor compliance. These children are bothered by their deformity, and if the curve is very severe, we do offer surgery. And here's a young boy who was not going to school because the kids were making fun of him. Here you can see his pre and post-surgical, but what's more important is to look how he looked before and after surgery. And this made a life-altering change in his life, and he became actually outgoing and gregarious. So the summary here is that that Scheuermann's kyphosis should be detected early and promptly referred. Just quickly, you can see scoliosis and kyphosis and skeletal dysplasia, like this spondyloepiphyseal dysplasia. Achondroplasia has kyphosis, Hunter syndrome, Hurler syndrome. Another patient. This is tuberculosis, which you may see in your country. This is very severe. It's infectious origin of the kyphosis. Camptomelic dysplasia, just showing you other conditions that you should recognize have spinal deformity kyphosis. Another kyphosis. And lastly, we'll talk about spondylolysis. This is very common, particularly in the athletic population. These children will come in with backache for varying time periods, and they usually only have back pain in the lower lumbar spine. Spondylolysis refers to a stress fracture at the pars inter articularis. It It is common. If you x-ray the general population, 5% of people will have it. Most won't even know they have it. It's the incidental finding on x-ray. But it increases dramatically with sports participation, particularly in hyperextension activities like gymnastics, volleyball, cricket, pitching. And we find in the United States with children doing one sport as opposed to changing sports, the incidence seems to be increasing. This is the youngest patient I've seen, a 3-year-old. And this just shows you various sports. It's very high with hyperextension activities and lateral flexion. So if you're doing a sports practice or you're screening children, this is something to be quite aware of as a very common source of back pain. 90% of patients won't even know they have it. It's an incidental finding. They always present with back pain made worse by flexion extension. You should do a careful neurologic exam, look for hamstring tightness. This is just looking for back pain with hyperextension in the lumbar spine, which is where the location of it is. This is a good test, the single leg hyperextension test, which is positive and the child complains of pain when they hyperextend with a single leg, it's suggestive but not diagnostic. So I always do this when I'm evaluating a child with back pain, in addition to a careful neurologic exam and a straight leg raising test. X-ray is all you need to take, a single X-ray. 80% of the time you'll see it on a regular X-ray of the lumbosacral junction. L5 is the most common level. You do not need to get, nor should you get, oblique views. These are high radiation and it's not necessary. These were commonly done in previous years, but I would caution you not to get these films. If I see a child with back pain, and even if the X-ray is negative, but I am highly suspicious of spondylolysis, I begin treatment anyway. And if it doesn't get better with standard treatment, then I go to additional imaging like MRI or CT scan. And I think I always tell the parents, if the X-ray is negative and my exam is otherwise unremarkable, that let's treat it first before we start spending money on expensive tests that wouldn't change treatment anyway. 90% of patients with spondylolysis get better without surgery. What's my treatment routine? My treatment routine is a non-steroidal anti-inflammatory for 2 to 6 weeks, accompanied by a back brace, full-time, 24/7, restriction from sports, and icing 3 to 4 times a day. If the child says, well, I can't do this, I'm in sports competition, I say, fine. We will not go on to the next stage of treatment or investigation unless you fail this 6-week course. So if they are not uncomfortable enough to follow this course, then we just let them decide when they want to follow this 2 to 6 week regimen of brace, anti-inflammatories, and icing. If they fail at 6 weeks, then I go on to further imaging studies. And there's debate whether you should get an MRI or a CT scan. For me, I get an MRI when I'm less sure of what the diagnosis is. I'm not thinking spondylolysis. Yes, it could be, but I'm not sure what's causing their back pain. Then I'll get an MRI. But if I'm suspicious of spondylolysis, I get a CT scan for the definitive diagnosis. Bone scans should not be obtained. There is no role for bone scanning in 2024. High radiation, low yield. MRI is the test you should get. Parents often wonder, if you make the diagnosis of spondylolysis, will it slip? In other words, spondylolisthesis. And the answer is 58% will slip a very small amount. There's no reason that these children, if they're asymptomatic, can't have full participation in sports. Now, all spondylolysis are not the same. Here's 2. One is a classic spondylolysis, the pars interarticularis fracture on the left, but the other is also called spondylolysis, but it's a pedicle fracture. This on the right has a better chance of healing than the one on the left. Here's a child who came in with back pain and an atypical scoliosis, We worked up the scoliosis and saw a stress lesion in the pars interarticularis, treated it with the back brace, anti-inflammatories, and icing. And 6 weeks later, the back pain is gone, the scoliosis is gone. And if the scoliosis doesn't get, if the pain doesn't get better, we find a spondylolysis, then we're talking about the possibility or need for fusion, L5-S1. Here's the 2024 standard of care, which is the use of pedicle screws. Another spondylolysis, and here's the fusion, 6 weeks out of sports and then return to full sports activities. Now, if you see a child with a spondylolysis at a higher level, L4, L3, what you should look for is tropism or asymmetry of the lumbosacral junction. Here's a child with an L4 spondylolysis, and please note that the transverse process of L5 are fused to the sacrum, so the forces are transmitted to L4, giving the L4 defect as opposed to L5. The take-home message is 90% of patients with spondylolysis get better without surgery and can return to full sporting activity. I'll skip this and skip this, and I'll summarize. I've taken a little too much of your time. I apologize, but spondylolysis is something you'll commonly see. Happens in 5% of the children. Most don't have any symptoms at all. If they do have symptoms, simple treatment can get them back to full sports activity. If they're asymptomatic, there is no reason to restrict them from sports. The defects at the higher level, for example, L4, are often more symptomatic. These more often come to surgery. I'll leave it at that. So I apologize for taking a little bit longer than I anticipated today. These are conditions you'll see in your practice. I hope I've given you information that'll, one, help you make a diagnosis, two, initiate a prompt referral to a pediatric orthopedic surgeon, and also to be able to counsel your patients as they come to you with questions that they've heard during their treatment by the other care provider. I wish you the best, and please feel free to contact me at any time if I can answer further questions. And thank you very much for your attention.
Muchas gracias al doctor Weinstein por su presentación. Él no va a poder tomar la sesión de preguntas y respuestas, así es que yo voy a tratar de darles respuesta a las preguntas que me han enviado. Una de ellas, o la primera de ellas, dice, ¿cuáles son las complicaciones más frecuentes de la cirugía correctiva de escoliosis? Y bueno, la situación es que la cirugía para escoliosis es una cirugía muy grande, es una cirugía que implica habitualmente una incisión de 30, 40, 50 centímetros de longitud, que involucra toda el área de la deformidad. El estándar es entrar por la parte posterior, o sea, es un abordaje posterior directo con el paciente acostado boca abajo, aunque ahora en los últimos años se han desarrollado técnicas a través de toracoscopía o endoscopía, en la cuales los abordajes son entonces por estas vías con incisiones más pequeñas, y se puede, lo que implica la cirugía es liberar los ligamentos adelante y atrás de la columna, retirar los discos, o sea, hacer disquectomías, y retirar las facetas articulares principalmente, para poder liberar y corregir la deformidad. Y entonces esto puede llevar a problemas. Uno de los más comunes es, número uno, no lograr la corrección completa de la deformidad, sobre todo si la deformidad es una deformidad muy severa. Entonces, curvas arriba de 60, 70, 80 grados o que tienen mucho tiempo de evolución, generalmente no podemos corregirlas por completo. Luego, otro problema relativamente común son problemas con la incisión, infecciones. Regularmente en una cirugía ortopédica la tasa de infección es alrededor del 1%. Las cirugías de escoliosis tienen entre el 3 y 5% de infecciones. Perdón. También puede haber dehiscencias de la herida, o sea, se abre la herida aunque no está infectada. Como es una herida tan larga, a veces tenemos problemas de cicatrización. Y bueno, puede haber fallas del implante, o sea, el implante se afloja y no mantiene la corrección, no lo colocamos bien. Habitualmente son barras largas que están conectadas a una serie de tornillos que van por los pedículos y agarran el cuerpo vertebral. Y también existe una, pues, relativamente baja posibilidad de daño a las estructuras neurológicas, que es menos de 1%, pero cuando sucede, pues puede ser una catástrofe, ¿verdad? Puedes tener una lesión neurológica definitiva o permanente. Y esas diría yo que son las complicaciones más comunes. Eh, Otra pregunta dice, en caso de escoliosis que se deja a libre evolución, ¿podría afectar el desarrollo normal de algunos músculos? En realidad, el problema de la escoliosis, como lo comentaba el doctor Weinstein, es un problema, vamos a decir que estético o de cosmesis, ¿verdad? O sea, es un problema de deformidad. Y en algunos raros casos, sobre todo cuando las curvas llegan a cerca de 90 grados, entonces pudiera ser que esas curvas produzcan una problemática con la función cardiopulmonar. Ese es el principal problema, no, no es un problema muscular en las idiopáticas. Obviamente que hay pacientes que tienen enfermedades como la atrofia espinal o espina bífida o la distrofia muscular de Duchenne, en los cuales el problema primario es un problema neuromuscular y la escoliosis es una manifestación de la enfermedad. En esos casos, pues sí, obviamente los músculos están afectados, pero no por la escoliosis, sino por la patología o la enfermedad primaria, ¿verdad? Y bueno, otra pregunta dice, ¿cuáles son las proyecciones de radiografías que como pediatras debemos de pedir en caso de sospechar escoliosis? Es una AP y una lateral de la columna en toda su extensión, estando el paciente parado. AP y lateral de la columna en toda su extensión, estando el paciente parado. Y lo dice, ¿es mejor referirlo a traumatología antes de solicitar las radiografías? Pues yo creo que eso es una situación ahí más bien personal, de preferencia de cada quien. Em, es posible que lo ideal sea enviar al paciente y que el traumatólogo haga las radiografías o las tomas radiológicas que requiere para no hacer una repetición y radiar de más al paciente, ¿verdad? A veces le pudieran pedir una radiografía que no está completa, que no estaba de pie, que no estaba en la posición apropiada. Y entonces cuando llega con el traumatólogo le tienen que repetir las placas y eso implicaría pues doble costo y doble radiación. Otra más dice, ¿puede especificar a qué tipo de paciente se debe realizar búsqueda de anomalías renales? Específicamente los que se han asociado con este tipo de deformidades o anomalías congénitas, tanto en el sistema urogenital como en el cardiovascular, son las escoliosis congénitas. Las congénitas, como decía el doctor, son aquellas como las que tienen defectos de formación, como las hemivértebras, o sea, se forma la vértebra nada más parcialmente o de segmentación o separación. Las barras que son, implican uniones anormales desde que se formó las vértebras, como el Klippel fail o cualquier otro tipo de escoliosis congénita. Entonces, nada más las patologías renal y cardiovascular son como 20% de renales y como 10% de cardiopatías congénitas asociadas a escoliosis congénita. Y la última, ¿las vértebras supernumerarias afectan o causan escoliosis? A lo mejor, no sé en esta pregunta, pero habitualmente estamos hablando de que algunas personas tienen 6 vértebras lumbares. En ese caso, no, no producen escoliosis, nada más lo único que producen son más frecuentemente la presencia de dolor lumbar. Tendrían que ser hemivértebras, o sea, faltas de formación de un lado de la vértebra, y entonces como un lado sí está creciendo y en el otro no hay vértebra o no se formó la vértebra bien, eso produce una deformidad. Bueno, creo que ya estamos sobre la hora. No sé si hubiera alguna otra pregunta o comentario, doctora Grecia.
No, doctor, fueron todas las preguntas. Muchísimas gracias otra vez por habernos ayudado a coordinar este módulo. Creo que fue muy importante, temas muy relevantes para el pediatra y pues con excelentes ponentes. Entonces, muchas gracias por haber estado aquí con nosotros. Gracias a todos los asistentes y nos vemos el próximo miércoles y ya iniciamos otro módulo que será de oftalmología pediátrica. Muchas gracias, doctor. Que tenga excelente día.
Gracias, gracias a ustedes. Saludos, buen día.
Buen día a todos.